I think that the biggest challenge is that it's such a broad field. It's an impactful field, obviously, because of the number of people that are involved with the cardiovascular disease and that are impacted by it. But yet, the scope of what we're dealing with at a meeting like this, or as a practitioner, or as someone who runs a Heart and Vascular Institute, is absolutely very broad. And that's both exciting, but that's a tremendous challenge. If you look at even the initial late-breaking trial in the plenary session, kind of outlines both the challenge and the advances. Right. One session, you're dealing with transcatheter aortic valve replacement, which is one of the newest devices and technological advances, and yet the results that were presented is another leap forward, all the way to the HOPE-3 trial, which is going to have a tremendous impact, but there you're going all the way back to preventing something from happening in a population that's at risk. And I think that really outlines some of our challenges. We are responsible for dealing with patients who have a life-threatening illness, but we are also responsible for trying to prevent patients from ever getting there, which is potentially more impactful. I think a couple of the trials that we mentioned earlier on, really, I would say the advances in technology is always have a big impact in a meeting like this. So that's in new ways to treat valve disease, transcatheter aortic valve replacement, that will have an impact in our practice pattern immediately. In addition, I do think that some of the preventive trials will have an impact in terms of how aggressively and how widely adapted aggressive treatment of high cholesterol population is. And lastly, it's a slow moving, not really slow, but it's a moving target in terms of how the PCSK9 inhibitors come into practice. And that's still relatively poorly understood by the practitioners, and that will continue to evolve. The general cardiologist is actually probably becoming more and more important. It's funny because you mentioned that, because as interventional cardiologists getting more tools, we're getting better at treating really the end stage, even though people may not have realized that by the time you have a heart attack, that's really end stage disease, because there was many opportunity in most populations to prevent that from happening. So one of the, if you will, the lowest hanging fruit, the area where we can gain the most is actually in prevention. And I think that if you look at the programs of this meeting, that comes across also. Clearly, one of the big areas is in treatment of cholesterol. Now, we've been able to treat cholesterol for a long time with so-called statins, but the two big advances, there are newer agents that allow us to treat patients who are refractory to the old-fashioned statins, and obviously that's big news, and so-called PCSK9 inhibitors, and we don't have the final results about how good they are at actually preventing heart attacks, but they're clearly going to have an impact, and that's a very active area. The other area that's really very active, kind of mentioned on the HOPE-3 trial, is identifying the population where we can get most bang for the buck. Since you're talking about a lifelong treatment to prevent something from happening, we need to make sure it's really worthwhile from safety standpoint and from financial standpoint. I think that it's a validation of many things that most of us cardiologists have been doing in terms of aggressively treating cholesterol for primary prevention in people who've never had a heart attack. But in addition to that, it gives us a better way to quantify what that benefit is. Okay? And it really shows the dominance of the impact of lowering the cholesterol. The impact of lowering the cholesterol seems much more important than the blood pressure effect that was seen in that trial. So I think it teaches us many lessons and gives us directions for going forward. UPMC has a unique opportunity because it's actually, from a size standpoint, it's actually larger than Cleveland Clinic or even any of the Philadelphia-based medical centers. And because we're so closely tied to the community, we have the capacity to work very closely with the whole population, who unfortunately have a relatively high prevalence of heart disease. And we have the ability to work at the population level to try to look at new paradigms for treatment as well as prevention. We haven't given up on the lifestyle changes, okay? Every Monday night football game, you're going to see the Primanti Brothers, the French fries and coleslaw on top of, a sandwich that's not so healthy looking to begin with. So even though that's part of the identity, the fact is we have not given up on changing the lifestyle. There have been advances. The number of people who smoke is less. Unfortunately, the number of people who are obese in Pittsburgh is not any less. So we're still constantly and aggressively working at that. We have to change the culture, and Pittsburgh in that regard is really a microcosm of the United States as a whole. What we have been as a field excellent at is exactly what you're talking about. We've taken the fatal component and have been constantly converting that to more of a chronic component of the disease. What we have failed to do is obviously to cure the problem. Okay? And in many ways that makes the financial burden of the disease even worse, because we keep the population continues to be sick with the problem but continue to need medical care. I think that some of the newer agents and lifestyle changes are attractive in that regard, in that they allow us to prevent the problem in the first place. That's why that's the area that can be most impactful.